All right, so good morning everyone. Bon matin tout le monde. Bienvenue au bureau de KPMG à Ottawa. Welcome to our offices, the KPMG offices here in Ottawa. My name is Dan Doran. I'm the director here at KPMG, and I lead the National Defense and Security practice, as well as when I'm not doing that, I try to do a little bit of work with the Canadian Army Reserve. So I'd like to acknowledge that this office is located in Ottawa and is on the unceded, unsurrendered territory of the Algonquin Nation, whose presence here reaches back to time immemorial. The Algonquins are widely recognized as the customary keepers and defenders of the Ottawa River watershed and its tributaries. We honor their long history of welcoming many nations to this beautiful territory and uphold and uplift the voice and values of our host nation. Further, we respect and affirm the inherent and treaty rights of all Indigenous peoples across this land. We will continue to honor the commitments to self-determination and sovereignty we have made to Indigenous nations and people. So as we come together this morning, we remind ourselves to respect and nurture our sacred relationship to this land, as well as to its first people, past, present, and future. So we are also delighted to support today's conference of the Defense Associations Institute and the Concussion Legacy Foundation through sponsorship, engagement, and collaboration, and are excited to have here today for your discussion around traumatic brain injuries, blast exposure injuries, and their effects on mental health. I can tell you as a combat engineer officer, these are definitely important issues and impact a lot of people in our trade. So really appreciate the work that's being done to support members of the Canadian Forces in this space. And so on behalf of KPMG, I'll turn this over to Joe, who will move us on.
Well, it's a great pleasure to be here, and I just asked if everybody could move up front a little bit for the speakers. Be greatly appreciated. I like the comfortable chairs down back too, but
that plan has been foiled.
get a little bit closer. And I want to say, part of housekeeping, just to lead off, that Brian Bruat, who's has a foundation called the Bruat Foundation, and is former honorary colonel of the Canadian Governor General Squidcards, actually is trying to provide the lunch today and the breakfast snacks. It's a great honor and a great pleasure to introduce our moderator, Tim Fleiszer, four-time Grey Cup winner and defensive lineman, and I think the only Canadian to actually win 4 Grey Cups with 4 different teams. And I'm actually going to start a rumor today that he's moving here to Ottawa because we need a crack at a Grey Cup again. Tim is a great person that works with veterans, and this topic area not usually considered a big military topic, but it's become a big military topic, particularly through the work of Tim and the Concussion Legacy Foundation and the Royal Canadian Legion and others who've dealt with this issue. So it's a great pleasure to have everybody here today and to have Tim here and his distinguished panel. And I'm going to hand off to him. You've got the Dollarama version. I'm the Deputy Director of the Conference of Defense Associations. Dr. Gary Fermier is not here today and sends his regrets, and our chair is overseas, General Thibault. But I'm going to hand off to Tim and say thank you very much. I'm looking forward to this morning's discussions.
Thanks for having us, Joe. And thank you for the... Okay, that's good. Are we good? Does that work? Excellent. So thank you to Joe. Thank you to the Conference of Defense Association for hosting us. Thank you for KPMG for hosting us. This is an incredibly important topic. And as of this morning, there was an article in the Globe and Mail about Shane and his story. And so finally, after years of working, this issue is starting to get national attention and the attention that it deserves. So the timing of this roundtable is very timely. I'll introduce some of my panelists, starting with Dr. Bureau, who's sitting next to me. Dr. Bureau has worked with Concussion Legacy Foundation for quite a while now. Samantha has both her PhD and her MBA, and supervises or is our international research liaison between our US group, our Canadian group, our group in the United Kingdom, and our group in Australia. And interesting to see that this is an issue that's starting to get attention in all 4 of those countries. And the second, I'll introduce Shane Nedohin, Master Corporal retired, and Shane will be telling you his story, but Shane has now spoken publicly about his struggles with mental health issues, which he believes is partly a result of brain injury. Finally, at the end of the table, Major General retired Denis Thompson, and when we started our work with the military, was able to get introduced to General Thompson and gave him the presentation. And part of what we're going to be talking about today is the science around this is complex. It's very difficult to put this messaging together in bite-sized quotes. And so I had delivered that presentation at that point hundreds of times, and General Thompson the next day sent me an email as a follow-up summarizing what I had told him. And I've never had anybody absorb and be able to give back to me the details of what we had talked about. And from there, thanks in large part to General Thompson, we very quickly, shortly thereafter, got a letter of support from the Chief of Defense Staff's office, which was very, very important. And we've had a very, very good experience so far in working with the Canadian Armed Forces and starting to get them to look at this issue more seriously. We have some folks in the audience here that were part of a group of master breachers who really worked internally, working with DRDC to bring this to the attention of the leadership of the Canadian Armed Forces. And subsequently, General Thompson joined our board of directors. So General Thompson, let's start with you. You've been instrumental in advancing our work within Canadian military circles. You agreed to join our board of directors and have actively advocated for people to take brain injuries seriously. Why?
Great question, Tim. First of all, I think it would, first of all, thank you for that very kind, generous introduction. I don't think half of it's probably a bit of a stretch, but that's fine. I'll take it as it is. When one regards Tim, if he asks you to do something, given his physical stature and reputation, of course you say yes. And so I was asked by Ryan Carey, who's present here today, and is also a member of my regiment, the Royal Canadian Regiment, if I would agree to meet with him and Tim Fleiszer in a park in Montreal, which I thought was kind of a dodgy undertaking, but I went anyway. And it was there that Tim and Ryan explained to me exactly what it was that the Concussion Legacy Foundation was up to and how much they had done for high-level amateur sports and for professional athletes, which is work that still goes on today inside of the foundation, both here in the United States and in the other countries that are mentioned, the UK and Australia. That convinced me, because it had already been brought to Tim's attention by Ryan, that there's a link between what happens in high-level sport and what happens in the military. There's clearly a link between the sorts of... Do you want us to use those microphones, or are these ones working?
This should be fine.
Is it close enough, or do I need to sing into it?
Maybe on your hands would be better.
Oh, okay, there we go. And so, I, of course, agreed to look into it, and as Tim said, the briefing was quite comprehensive, and I was convinced that it needed the attention of the military hierarchy. So, as he mentioned, we engaged with the Department of National Defence and with the Canadian Armed Forces and with Veterans Affairs Canada, and I think we managed to move things along. What was it that convinced me? Well, first of all, I heard about Project Enlist, which is an initiative where anyone, frankly, can pledge their brain to a brain bank in which is in Boston University, but I guess it's more of a universal brain bank now, to have an autopsy done after they're dead, of course. We wouldn't want to be doing these things if you're still in life, in order to determine whether or not you suffer from CTE. And that project, which had been running for some time in the US, determined that at the time, this is 2019, 66 of 102 autopsies confirmed that there was CTE amongst these 102 military veterans in the US. And clearly, given that we're all in the same conflicts together, there must be a link to Canadian soldiers as well. I was also introduced to Operation Brain Health. Right, that's my evil.
Perfect timing for that.
Yeah, that was my evil minion speaking. And Operation Brain Health, which is an initiative to make sure that those people who may be suffering from mental health issues related to traumatic brain injuries follow a certain course of action on in their daily routine in order to stay as healthy as possible. And I was made aware of the helpline that the Concussion Legacy Foundation has, and I think is very useful as well. And finally, because I pledged my brain, I also decided to participate in a current study that the Concussion Legacy Foundation is running right now to study the brains of people while they're still alive. And that's being done by the Center for Addiction and Mental Health in Toronto, where I had an opportunity, as did Tim and others, including astronaut Mark Garneau, to go and have your brain scanned, both with an MRI and a PET scan using a new tracer to determine what the markers are eventually for CTE. I won't go too deep into that because Dr. Bureau will immediately correct me because I'm probably going to make some mistakes. So the reasons are many and varied, but they all circle around one thing, and that's the leadership of Tim Fleiszer, who's been running this foundation now for, 10 years almost. Right, so that's it, Tim.
Thank you, and thank you for discussing some of the programs. Anybody that wants to access those programs, and our purpose of being here today is to hopefully reach some of those people that are out there that are potentially suffering from these symptoms. If you're a veteran, if you're serving the Canadian Armed Forces, and you say, well, the stuff these guys are talking about today, I think I may be affected. We want to help you. And you can find that help. You can get in touch with us at projectenlist.ca. As Denis mentioned, we've got some wonderful partnerships. I'm very pleased to say that here in Canada, we are leading the world in some aspects of this research. We do work with the Brain Bank at Boston University. We also work with the Canadian Concussion Center at University of Toronto. And so for Canadian veterans that want to see their brains studied in Canada, we do have that partnership as well. And as General Thompson also messaged, the work at the Brain Health Imaging Center with Neil Vazdev and Isabelle Boileau and their team is there to try and diagnose CT in vivo. Again, this research is leading the world, and being able to diagnose a disease that right now we can only do via autopsy would be game-changing for this field. So thank you for the participation in that. Dr. Bureau, what are some of the symptoms associated with brain injury that Canadian military personnel should be aware of? And for those that are watching at home and are thinking, am I affected by this? What should they be paying attention to?
Yeah, so when we think about brain injury, we look at buckets of symptoms. And the difficulty with the brain is that we don't have the best tools to study the brain as it is, right? We have imaging, but we can only see so much. And a lot of these injuries, we classify them maybe not appropriately in terms of, we call them mild traumatic brain injuries. And we know that this isn't a mild injury to many people who are suffering. The symptoms are very real. It doesn't mean they're any less serious, but that is where the nomenclature is right now, and that is what we're using. So concussion would fall under that category. And when we think about concussion, because of the changes happening in the brain, we don't have scans right now that are sophisticated enough to show us when individual brain cells are damaged or some of these biochemical changes. If we have more severe brain injury where we see structural changes in the brain, yes, we can pick those up. So the people who are really falling through the cracks often are people who do not necessarily have damage that will show up on a CT scan or an MRI, but are suffering symptoms. And this is because they probably have a handful, maybe more neurons that are impacted by either a force to their body that caused their head to shake rapidly or to their head directly, and they get symptoms in 4 major buckets. So we think about them as cognitive symptoms, so maybe you have poor concentration, your memory is off, maybe difficulty with tasks that would normally be easy to you, you're a bit slower. So that is a cognitive bucket. We see behavioral symptoms, which we look at, anxiety, depression, maybe a bit of agitation, just low mood, or just changes in your normal affect. It doesn't always have to be that you are slower or worse off. Some people, maybe they are more hyperactive following these injuries, but any change in your normal behavior is something to look out for. We see changes in sleep, and again, it's not as specific as, you're sleeping more. Some people sleep less. We have REM sleep disorders may come about, and then we have physical symptoms. So a lot of people, these are the ones I think that people think about the most. So headache, sensitivity to light, sensitivity to noise, maybe nausea, dizziness. But if you've noticed all the symptoms I've listed off, they're not specific only to brain injury. And this is what makes it difficult, is thinking, well, is my headache from an injury I sustained? Is my change in mental health from an injury? Is it from something else? And this is what makes it very hard to diagnose. So the way we like to look at it is looking at if you were exposed to a hit to the body or the head, and then within either immediately or within a few hours or a few days, you all of a sudden start feeling some of these symptoms, that's when it's appropriate to start thinking, hey, maybe did I suffer a concussion? Did I suffer several injuries that over time have built up? Because Denis had mentioned CTE, and that is not necessarily an injury, it's a disease, it's a different scope of the problem. But this is what makes it difficult. So a lot of it is really having to go back and think about, did I receive exposure? Could my brain have been injured? And could that maybe be explaining my symptoms? And it doesn't mean that your symptoms can't be explained by other things too. But this is the difficulty with brain injury, right? It's not as simple as a broken bone where you go and get an x-ray and we can say, yeah, your bone is broken, we're gonna put a cast on you and you'll be better in 6 to 8 weeks. We just don't have the sophisticated information or technology to be able to do that. So there is a lot of burden on the patient to be able to tell their doctors and their family what they're experiencing, but then there's also a lot of doubt because you aren't, people don't recognize in you what you are feeling all the time. So it just makes this entire conversation a bit more convoluted, unfortunately.
Dr. Bureau, Dr. Lee Goldstein from Boston University says that brain injury is often misdiagnosed as PTSD. Can you comment on that?
Yeah, I'd say in the military populations and populations where domestic violence, for example, is experienced, that is the population we're seeing this, and it's because we know PTSD is linked with trauma, exposure to trauma. But in these populations, they're also being exposed to injury. So in a sports context, we're not seeing a lot of PTSD and brain injury showing up simultaneously, and there's been studies to look at this. But in a military population, for example, there is trauma happening, there is injury happening. We also know that part of the PTSD etiology is not forming memories properly. So there have been a lot of questions asked, is it because maybe the brain injury is damaging the part of the brain that can help you create those memories properly and store them? Are there other things going on? But when we look back to the symptoms I mentioned earlier, sleep and behavior, those symptom buckets are also very common in a PTSD clinical course. So it gets very difficult for people to say, well, what's the cause of these symptoms? Is it from PTSD? Is it from brain injury? Is it both? And that is why we're seeing a lot of these misdiagnoses. And I think in the military population, because so many people are impacted by PTSD, it is always top of mind for people when they are looking at these symptom profiles, when people are coming back or in the field. It's something that physicians are thinking about. So of course it's going to be something that they are going to investigate, and when the symptoms line up, that's usually how they're making these diagnoses. Again, we don't have a scan or a blood test that will say, yes, PTSD positive, we know what you have. And that is why we have, I think, some of these misdiagnoses. And you can also have both. You can have traumatic brain injury and PTSD, which then makes this even more complicated.
So Shane, we're sitting here having a very academic discussion about all this. For you, this is all very real. Do we maybe discuss what your symptoms have been and talk a little bit about your experience?
Yeah, so
When my symptoms first started to develop, the best word I can use to describe them is insidious. Little things here and there, you get your bell rung, you go home, you sleep it off, you wake up, you're irritable. So I, over time, and even pre my time at JTF2, had blast exposures with using recoilless rifles and like anti-armor weapons, etc. So then when you get to the unit, you're immediately exposed on a day-to-day basis. So as these things occur, the symptoms, it's little things. So at first it started with some irritability, but I was like, okay, well that's, I did get my bell rung yesterday, so I'm a little bit more irritable today. And that was kind of common sense. We knew that, but we weren't fully understanding science. So I started with like irritability, headaches, dizziness, and then, as things progressed, I started to experience changes in my body. It seemed like no matter what I did, like I would work out hard and like I just would be putting on weight. And so I went to the doctor. I thought maybe I had like low testosterone, like something's going on with me. And they tested my blood and they said, well, you have hypothyroidism. And I was like, oh, okay, like that. I don't know what that is. And they're like, yeah, so again, I don't know the science behind the connection. So that happened. And then like all of a sudden I started to lose focus. I couldn't concentrate on anything. I used to read all the time, and now I can't read a book. I can't focus on a sentence long enough. I struggle with my train of thought. You guys can probably hear as I speak right now that I struggle to put my thoughts together. Everything's happening, but I struggle to get the words out. So the concentration issues, and when I really started to notice, like, okay, there is something definitely wrong happening in my brain, I would be like, I'd be deading up a charge and I wouldn't remember doing it. And then I'd go to blow this charge and I'd be like, did I dead it up? I don't remember. And that's dangerous. And that was at the end when I was like, I'm done. And they always say what doesn't kill you makes you stronger, and nothing could be further from the truth. I think when it comes to brain injury, I felt the more I got exposed, like the slightest thing would make it worse. So I'm not sure if that fully captures the question, but please feel free to dig, because I probably went a few avenues there.
You did it perfect, and it's interesting. Every time somebody like you shares symptoms, we always hear, from people out in the audience, like that's what I'm going through. And so thank you for doing that. And Shane, how do you believe you were injured?
Well, I believe it was just repetitive exposure to blast over time took its toll on my brain.
What were some of the specific activities?
So pre-CANSOFCOM, I can say that I've probably personally fired over 100 rounds of 84 millimeter recoilless rifle, and then been an assistant range safety officer for hundreds of rounds. We didn't think about it back then. It would just be like, well, you're the qualified ARSO. You go stand out there in the line. Next guy, okay, next guy, next shooter, next shooter, next shooter. And I did share this story with Graham Richardson, but like I can remember one event. We were at an exercise, and I was the ARSO on the 84 millimeter range, and I was there from like first light to last light. We were firing all day, and the stack of rounds, like there was hundreds, and I started to feel really weird throughout the day and not good. And then ironically, it was the last shooter that came up and he fired, and my nose just exploded with blood, like both nostrils. And I've never had a nosebleed like that in my life or since. And like, I couldn't stop it for hours. And then of course I felt like garbage. I knew something was wrong, but again, the science wasn't there. So that's an incident I can say, like, there's an example of just like the regular military. Now move over to the CANSOF side. You know, as a member of JTF2, you don't even have to be a breacher. Right from day one, you're exposed. You're shooting, you know, pistol, carbine, shotgun in enclosed spaces. You know, depending on what the wall material is made out of, that blast overpressure will bounce around more or less. Especially concrete was the worst. At one point, further on, when they started to recognize it, they started to put these blast sensors on us, these PSI gauges, and you know, they would get set off all the time just from gunfire. So, and then of course you put in the charges that we would use. So, one sec here. But yeah, so just as a member of CANSOF, and it's not just JTF2, like certainly CSOR and other units that deal in any type of CQB, you're just exposed on a daily, weekly basis to these overpressures in interior and exterior. And like I fully recognize, like, we can mitigate these things in training, but at some point in time, like in the military, you're going to have to be exposed to blast exposure. Like it is just a reality of the job. But I think now that we're starting to understand a little bit more, we can mitigate those. Did that kind of answer your question?
Absolutely. Dr. Bureau, one of the things that we hear quite often is when we're talking to veterans is we talked about brain injury and they say, well, I've never been knocked out. I've never had a concussion. What's your comment on that?
Yeah, I mean, most people who sustain a concussion are not knocked out or lose consciousness. That's a more rare symptom and probably a sign that it's a bit more severe of an injury if you are losing consciousness. And I think for a lot of people, that was how we were told about, you're knocked out, this is something we need to think about. But even looking back, to go back to football, I mean, getting your bell rung, very common terminology that's been used, and now we recognize that and use that when we're trying to parse out from people what they may have been exposed to. We actually use that terminology saying, have you ever gotten your bell rung? Because that is also a brain injury, and they don't need to be severe. It doesn't have to be a car accident. It doesn't have to be these very severe traumatic injuries to have damage in the brain, and that is where some of the conversations about neurodegeneration and some of these other diseases become complicated, because most of these people, their exposures actually aren't even resulting in symptoms. So they wouldn't be classified as concussion. That doesn't mean there's no damage. It just means there's not enough damage for you to perceive a change in your symptoms or what's going on in your body. But to put it simply, you certainly do not need to be knocked out to have a brain injury. And many people, majority are not in that process.
Shane, you received a letter from Veteran Affairs denying your claim for disability benefits. Several of your fellow soldiers have also received similar letters. How can CLFC, the CDA, the Legion, and other organizations that serve veterans help you and others in a similar predicament?
Well, I think, first of all, that Canada is years and years and years behind the ball with science in regards to this. So I'm not going to purport to understand the fine-tuning of how VAC and the system kind of makes these diagnoses, but what they need to do is they need to actually do the research. They need to believe us, first of all, when we tell them that we are injured. Like, that's first and foremost, believe us. Number two, Canada needs to join the 21st century. And this is very anecdotal, but I know I have friends I speak to in the American military, and they're light years ahead of us with diagnosing soldiers with blast injuries, and it gets ignored here. It seems like it's not recognized as a legitimate injury. That they need to recognize it, and they need to actually. I'm not sure who these doctors are who are coming up with this. basically, my letter says, do you want me to read out just that little part? There is no evidence of closed head rotational accelerations that required medical attention in your medical evidence, and no events of trauma-induced altered mental status are provided. Repetitive exposure to blast injuries is not supported in the expert medical literature as an etiology of subjective symptoms or cognitive decline. Like that, you're literally denying the science, you know, for a government that says, you know, we follow the science. They don't. There's zero science. I don't know what doctor put that together, but my child knows that explosions cause brain damage.
Dr. Bureau, what's your comment on that?
Yeah, I mean, I think we love to be controversial and have controversy in science. We like to argue over nomenclature and things like this, but there is substantial evidence in the literature that blast injury is a cause of traumatic brain injury. We've even had studies here in Canada that have shown structural damage following, especially from breaching activities. So in 2021, a study was published showing that there was damage to the frontal area of the brain, which would explain cognitive symptoms, because that is where we see a lot of our executive functioning coming from. In 2015, there was a study that came out where it was an anonymous survey that they sent to military personnel, asking them to report on symptoms and what their exposure were. In many of these instances, exposure to both high-level blasts, so those incoming munitions, and low-level blasts, which is a little less studied right now, which is where I think a lot of this controversy comes from, is that's more from firing artillery. There hasn't been as much research in that domain, but regardless, we're seeing time and time again soldiers coming forward with these cognitive and behavioral difficulties, and it has been documented in the literature. And the biggest argument is that we don't know the exact mechanism of a blast injury versus kind of like a induced injury, like a hit to the head or the body. But regardless, we're seeing the same symptoms appear, and we do know that blast injury is associated with brain trauma and structural damage. If we remember what we talked about before, most of the concussions we're seeing people have, we can't even detect structural damage in a scan. So you'd have to imagine what's going on in the brain if we're now seeing damage that we're picking up on MRIs and PET scans and functional tests. That to me indicates that this is, a severe injury, and of course we're going to see symptoms. I mean, thinking that you got, a spontaneous nosebleed, which I know is not rare after talking to many of the guys that you served with and people we work with, that has to be a lot of force coming to the body to be causing some of these things. So to think that it's isolated to just a nosebleed or some of those physical symptoms and not harming your brain just feels like we're just not addressing the risk appropriately.
And if I may add, you referenced the study that came out in 2021. I was actually a part of that study. So, I had my brain scanned every year for 5 years. And yeah, I need to throw that out there.
So General Thompson mentioned at the beginning results out of Boston University, specifically led by Ann McKee, Dr. Ann McKee, and I was in contact with Dr. McKee yesterday. And these are unpublished numbers, but great credit to them and to our colleagues in the U.S., Chris Nowinski, Bob Cantu, Lee Goldstein, that have been just leaders in this. And this is unpublished, but of 307 military brains, 179 were diagnosed with CTE. And so that's almost 60%. So this is a problem. And again, we don't know how pervasive that is. We need to keep looking, continue to have the research. But yes, I think we're beyond wondering whether or not there's a relationship between blast, military service, and brain injury. General Thompson, you're quoted as saying, "Suck it up, buttercup is no longer an acceptable strategy in dealing with brain injury." What do you mean by that?
Let me just pile on to what you just said. I think it's important to note that the United States Department of Defense, the Deputy Secretary of the Department of Defense, recently published a letter on the 8th of August of this year that Tim shared with me after doing his own personal research. And in there, It speaks directly to the effects of blast overpressure, and it goes so much into a great deal of detail, including which weapon systems and which military occupation codes are at risk. And clearly, there are some weapon systems in there that Canada shares with the United States, including the 84 millimeter recoilless rifle, which we heard Shane talk about, and one which I remember from my own service. At the end of a range day, nobody wants to turn in ammunition. So what do? You line everybody up and you fire a whole bunch of rounds all at once. And of course, those people are all exposed to these blast overpressures simultaneously. You're told that if in the old days when it was a Leopard 1, you run by the second road wheel of the Leopard, because when it fires, you don't want to be anywhere further forward than that, because the blast overpressure is too much for you. Well, guess what? At the second road wheel, it'll almost knock you down. Same thing if you're doing an assault as an infantryman with a LAV 25, with the old LAV 3. If you run anywhere forward of the turret, or if you're beside the turret, you can certainly feel the concussion of a 25 millimeter Bushmaster when it goes off. So all of these blast overpressures have been documented by the U.S. Department of Defense, and I certainly agree with you, Shane, that we need to just accept the work that they have done and include it in our studies, et cetera, and in our adjudications of cases like Shane's and others. So, but to answer your question, this goes back to the days of the Romans. I mean, the Romans wore helmets. They understood that head injuries were important, but they wore them because they didn't want to crack their skull. I don't think they were too concerned about concussion at that time. And then later on, we added body armor, and of course we added ear protection. But none of those things protect your brain, which is very delicate. So sucking it up, buttercup, or get back on the horse, these are solutions that don't necessarily work. And while they intuitively knew that the brain needed protection, they didn't understand exactly why. So what we need to do today is to train smarter. And what's happened in high-level amateur and professional sport is that they've changed the paradigm of training regimes in order to reduce the amount of full contact that goes on inside of practice. And we need to do something similar or something that's synonymous inside of the military. And that could be something as simple as, and you might remember this, Shane, the 6.5 millimeter insert in the Carl Gustaf. Right? It doesn't make much of a bang, but it makes the soldier go through the drills that are necessary to fire a Carl Gustaf. Although my experience in CANSOF's not as deep as the gentlemen that are here today, there's got to be a solution to the full blast charge to go through a wall that doesn't cause the amount of blast overpressure that these folks are exposed to. And I certainly agree that in close quarter battle, yes, you can feel it. There's a ringing sound it makes if you're inside a steel CQB range. It's not maybe not as bad when it's lined with wood, as I recall is what we had at Dwyer Hill, but it's still there. There's still that you can still feel it, especially if you're firing hundreds of rounds, literally a day. So change the training regime is probably the only answer, but we are dealing with, and don't take this the wrong way, Shane, a whole bunch of type A personalities, and these guys, they love to charge hard, and they're not going to let up even unless they're informed, first of all, and ordered to in many ways by the chain of command. So.
Can I pile in on that? Yeah, so I can't speak to the regular military. I can speak to, I know JTF2 has changed their training practices quite a bit, and you were saying, we still do need to do realistic training, but for example, okay, we recognize in training, we're gonna put up this charge. We recognize that in real life, in operations, you're gonna be standing here, but because we're in training, we're gonna go stand back there. That is already being done, and I can say from speaking personally to the people who are running the training, because I'm still in contact with them, I know that they care about the guys. They care, and they are mitigating it. Now again, we don't know what we don't know, so that work continues to be done and needs to be done. But yeah, it's definitely we need to mitigate. I'm not sure I'll agree about firing that insert on the 84. God, those were awful. But you're right. We need to limit the exposure because you can't have guys up there and girls up there, firing off round after round after round. They do at some point need to fire it live and see what it feels like, because when you fire in combat, you don't want that to be the first time. Right. But yeah, we can't just put them up there and, like you say, do the old fire off all the ammunition and everything.
So as a former athlete and somebody who's spent a lot of time around sports, I'm always fascinated by the interplay between the military and sports. And I'll just say, when you guys used to come walking through the room every year in the CFL, we'd have a military appreciation game. And when you guys came walking through the locker room, we'd all sit up straighter. Because it's like, well, there goes the real badasses. But always so interesting when I interact with military folks. A lot of big sports fans there as well. And it's interesting. You mentioned football and what you've seen in the last two collective bargaining agreements in both the NFL and the CFL is real restrictions about impacts in practice. Back to what Dr. Bureau's talking about the importance of reducing non-concussive impacts to reduce risk. And the one that everybody really seems to react to as well, Dr. Bureau and I were recently down in California with Ann McKee at a conference, and it was mostly MMA fighters and military personnel. And George St. Pierre, who I think we're all big fans of here in Canada, was actually one of the first guys where he stopped sparring in practice leading up to fights. And so this whole idea of you got to train like you fight that you always hear in the military, we've seen a movement away from that in sports. Dr. Bureau, our colleague Jeff Brooks at Western University, who was a former linebacker, had accelerometers in the helmet of the Western varsity football team for 5 years, measured every impact they took, practice and games, and was looking at reaction time. And when you think about performance, which is something that's so important in sports and so important in the military, I always think about reaction time being towards the top of that list. And when you talk to those top performance guys that train all pros, they're always very focused on improving guys' reaction time. Can you talk a little bit about Dr. Brooks's research and what he found?
Yeah, so his research was really interesting because I think a lot of the work we've been doing on repetitive head impacts, which we use essentially as a proxy to figure out how many times you may have been exposed to trauma, because we don't know what impact is going to cause what damage in the brain. So the best way to proxy this is how many times have you been hit, either head or body, and let's add it all together to get an overall risk profile. And a lot of times we're looking at this regarding CTE, a really popular topic. It's in the news, and importantly so, because it is a really devastating disease. But what Dr. Brooks did is he actually took a similar approach using accelerometers to try and identify risk, but to look at a performance measure in reaction time. And what he found is that proportional to the number of impacts the players were taking, their reaction time was decreasing. And I think a lot of people would say, oh, that's common sense. You hit your head a lot, your reaction time is going to go down. But what I think is most interesting about his work is that in the off period, so if you think about a standard, Canadian university football league play, they have, quite a few months off in the summer. The Canadian school year is already shorter than the American one. You'd think maybe that's going to rebound a bit, and what he found is that it actually did not rebound. So now this is their new normal. This is their new baseline. So then they go into the next season, and their reaction time has decreased from the previous season, and they're going to go through it again. And what he saw is that over time, their reaction time continued to decrease proportional to the impacts that they were taking. And he was saying that about 20% overall decrease in reaction time. And to anyone who is in an occupation where it's life or death, like the military or professional sports, where that's probably could be the difference between being a starter and maybe not even being on the team, this is an important metric for performance. You don't have a lot of time to make these decisions. So to see that, besides the health outcomes that we know we're seeing, we're also seeing performance outcomes that are negative from this exposure. So you'd think if you want to put the best people on the field, out in combat, that you'd want to protect this mechanism as well. Because again, it's, these split-second decisions are very important. And I'm sure I don't have to tell any of you here how important those decisions really can be, and we're seeing this decrease in reaction time, which is concerning.
Yeah, interesting, and interesting to see that trend in MMA is really spreading, where so many folks are really reducing or not sparring at all leading up to a fight. So Dr. Bureau, this can all be a little bit confusing. Concussion versus CTE versus white matter change. Can you make sense of this a little bit for us? Like, what does this really mean?
Yeah, and I think it's an important discussion point because it is confusing. Even the scientists can't get on board sometimes with what this nomenclature is or what we're talking about. And the way I like to think about it is you have concussion, and let's think about that as an injury, right? So it's following an event, you're showing symptoms, this is something we can rehabilitate. And most people following concussion, if they are treated properly and in a timely manner, the gross majority of people are recovering within 1 to 2 to 3 weeks. Then what we have is, people have probably heard of the term post-concussion syndrome or persistent post-concussion symptoms. And this is that bucket of people who have had a brain injury. Maybe they were treated properly, but for whatever reason, their body's just not responding. And they're seeing symptoms last for longer than a month is typically the threshold that people will diagnose. Sometimes it's 6 to 8 weeks. But regardless, these symptoms are persisting beyond what we would consider the injury portion of what's going on. And you're moving more into a clinical syndrome, and this is a long-term thing that we're working on, and some people suffer for years, decades. There's really no good reason we have why someone who has a very similar injury to someone else, why they may not recover quickly, but that is what is happening in that bucket. We then have CTE, and CTE it's a neurodegenerative disease. So essentially your brain cells they're dying. You're not recovering your brain cells. It's not something that we can do. So over time, very similar to an Alzheimer's or a Parkinson's, your brain is breaking down. So that's why this is very different than an isolated injury of a concussion or even those persistent symptoms, because we know what's happening in the brain is a little bit different. What gets tricky is a lot of the symptoms overlap. But the way we like to look at CT is your risk factor is not the number of concussions you've been diagnosed with necessarily, so a diagnosed concussion. It's the accumulation of all the impacts you've had, because we don't know which ones are causing the damage or not, but we do try to think of it as, say water is hitting rock, right? One raindrop, you're not going to see any erosion in that rock. But if the same drop of water or water keeps dropping on that same portion of the rock over and over and over again, we will see erosion. And that's why I like to think about something like CTE. It's this buildup of trauma that eventually over time things start to wear down, and we start to see these changes that fall into that neurodegeneration camp. And then you mentioned white matter change, and this is something that's a bit newer in the literature, in the media, and it's because we're seeing a lot of people who've had certainly exposure, they're having very severe behavioral symptoms, but then we look at the brain and we actually don't find CTE. So it doesn't mean their brain's certainly not normal, right? It doesn't make sense for someone to just be going about their day and have their life be normal, and then all of a sudden over years they have complete changes in mood and behavior, aggression, impulsivity. And what we're seeing is in these individuals, we're starting to see a breakdown of what we call white matter. So if you think about a brain cell, we call it a neuron, as your phone charger. So the end that plugs into the wall, that's the body of our cell, and information's coming in there. And when you're charging your phone, the electricity is going down the cord into your phone. So what's wrapped around your cord, it's insulation to allow the electricity to conveniently go from the wall into your phone. So when you think about the white matter in your brain, it's very similar to that insulation on your phone charger. So when you think about your neuron, there's going to be damage now to the protective fatty tissue. The reason we call it white matter is because it appears white on scans, and it's different than the gray matter, which is the part, if you're using the cell phone analogy, that's plugged into the wall. When we see that breakdown, neurons can't communicate effectively because that signal that's going down is not efficiently being transmitted. And this is something now we're starting to see. We're seeing it in the US. We're starting to look at it more widespread as an explanation to what may be happening. And I think what's hard for people is CTE has been in the news a lot. So we see certain symptom profiles, and the first assumption is, oh, well, I have that. I have CTE. And that's devastating. It's a neurodegenerative disease. We can't cure it. We can't diagnose it. That's an awful thing to think that someone may have. But now we're starting to learn that there's so many other things that happen in the brain that are equally as serious, just not as looked at, that are happening from exposure to brain trauma. But this now complicates the conversation. And when you think about trying to get a diagnosis, now that we have all these things on the table and we don't have a scan, a blood test, a saliva test that can tell us which one of these things you have, it leaves people in a really difficult position. But all that to say, repetitive brain trauma is just, it's not good, right? We need to understand the acceptable level of risk as related to the occupation, and then what is maybe unnecessary. And I'm not here to tell the military how to operate. That I don't feel like that's my role. My role is to say, look, this is what the science is showing. And I was a former ice hockey player. I went and played in the NCAA, and we certainly were not hitting in practice because, I don't think it was for brain injury, unfortunately, at the time, but it was certainly for physical injury. There's no point of putting a player out who's injured. So again, what can we do to reduce as much risk as we can while still having people who are prepared to, serve, is really that fine line. And that's what I think our new challenge is how do we keep people as healthy as they can now, protect them when they come out, and give them the resources they need so people like Shane aren't suffering without any resources available to them, and just having everyone on the same page, like let's just move forward and figure out, like this is a new problem for us all to work now. So instead of fighting over what is what, let's just all work together and acknowledge brain injury is causing problems. We don't know all the details yet. We'll learn as science evolves, but we all have a role to play in solving this problem, and let's just all work together to do that.
And if you're suffering from symptoms, if you're a member of the Canadian Armed Forces or you're a veteran and you're watching this today, or more importantly, if you know somebody who's suffering from symptoms, if you're a caregiver, because asking somebody who's neurologically compromised to self-report is a terrible strategy, right? It's like asking somebody who's had a couple of drinks if they're too drunk to drive. So a lot of times what you need to have that person that they trust, that friend, step in. Like the culture that the military has. Tough to take a knee sometimes, and sometimes somebody needs to step in. And so if anybody needs help, they can come to our website at projectenlist.ca and come in through our support line. We'll connect you with best available medical resources in your geographical area. And if you need help with your paperwork for Veteran Affairs, we have Carolyn Hughes, who's here today from the Legion, who's been a fantastic partner for us over the years. I know, Shane, you used the service originally to first put in your paperwork. And so, if this is resonating with you, if all these things sound familiar for yourself or for somebody that you care about, please come in. We're here to help. Shane, you've had several friends that are suffering from symptoms. What do you want to see happen? How can we help you, and how can we help them?
Well, first of all, I think we want to be believed. I think we need, again, going back to like the system that is looking at all this medical evidence. I don't know if it's deliberate. I don't know what the issue is, but they need to change the policy, the medical policy that they're basing these decisions on. That's something, just so through advocacy. And, I have my friend Justin here today, who's, I always joke, I said, you got the wrong guy. He's the guy you should have had up here because he's a lot more educated about this stuff than I am, suffering through this stuff. And it just seems like everyone we talk to, we're hitting a brick wall until you contacted me. And what can you do to help? I'm not going to sit here and purport to know every single thing that needs to change about VAC, about whatever else, but I do know that whatever medical science they are using right now is outdated and inaccurate, and that needs to change. There needs to be a complete review of the medical policy.
General Thompson, today's your last day serving as the colonel of the regiment, if I'm not mistaken.
You are correct.
So let's give the final word to you. What do you think people should take away from what they heard this morning?
Well, first of all, I think we should acknowledge the fact that that there are soldiers and operators who are inside of the Canadian Armed Forces that have given their all, and they need to be compensated afterwards. I'm happy to hear, and I'm happy you mentioned it, Shane, that there's been some changes, at least inside of CANSOF. I've certainly noticed difference when I've gone around and visited the various battalions of my regiment, which is good, because I left service in 2017, long before this was really thought of as a serious issue, and I had been out of the country for 3 years at that point. So this has evolved quite a bit. So my final word is to acknowledge those that are suffering and to encourage them to get the help they need and to go see those who can help advocate for them with VAC or in some cases with their chain of command. And just to emphasize that point, I have in my pocket here somewhere, hang on, must be the other pocket. It is indeed. Oh, look at that. It's the colonel of the regiment's coin. Now I only have one, so sorry, Justin, Shane's sitting beside me. In any event, this coin is my last coin that I get to give out as the colonel of the regiment, and I want to give it to you, Shane, in acknowledgement of all that you've done to raise the profile of this issue, and to thank you for your service. So, on behalf of us all, so it's really my coin and it's from my regiment, but it really is recognition of what you've done for this issue for the entire Canadian Armed Forces. Thank you.
Thank you very much.